Hello, and welcome to the Type 2 Inflammation Connection in CRS with Nasal Polyps, optimizing patient identification and targeted treatments. This is the first part of our two-part series, Filling the Gaps in T2 Inflammation-Driven CRS with Nasal Polyps, Unmet Needs and Identifying Patients for Biologic Treatment. I'm Flavia Hoyte from National Jewish Health, and joining me today is Christine Franzese from the University of Missouri.
Thank you. It's so good to be here.
Okay, so without further ado, we'll start with the housekeeping items. So, first, thank you to PeerView for providing this session, and for Regeneron Pharmaceuticals and Sanofi for providing the educational grant for the symposium. A reminder to please look out for additional polling questions during the presentation, and also submit your questions along the way, and we'll answer them during our Q&A session at the end. In terms of visiting us online, it's peerview.com/back T2INCRS with nasal polyps. And the slides and practice aids are accessed in the activity menu. You can access them now, and you can download them after the session. So moving right along, goals for today. During the presentation, we're going to learn a couple things. One will be that individual characteristics of disease and clinical considerations can be used to determine which patients with CRS with nasal polyps are candidates for treatment with biologic therapy. And then importantly, we're going to look at incorporating biologic therapy into the treatment of patients with CRS with nasal polyps and talk about how this should be guided by the latest evidence, inflammatory endotypes, and presence of type 2 inflammatory comorbidities. So, first, we'll talk about the unmet needs in CRS with nasal polyps and the role of biologics in hopefully filling these needs. So, what is chronic rhinosinusitis? It is an inflammatory condition with multiple phenotypes. So, there is a time point here. It has to be greater than 12 weeks duration of greater than or equal to 2 symptoms. So, the symptoms include drainage, either rhinorrhea, postnasal drip, or both, nasal congestion or obstruction, facial pain, pressure, fullness, and decreased sense of smell. And again, you need two or more. Most of our patients end up having all of them in some capacity or another. And then, in addition to the symptoms, you also need objective criteria of inflammation. So, greater than or equal to one, either by endoscopy, documenting drainage, mucosal edema, or polyps, or a sinus CT scan that shows inflammation of the paranasal sinuses. And in terms of chronic rhinosinusitis, we know it's actually quite common. Approximately 14% of adults in the United States would meet these symptom criteria for CRS. The typical age of diagnosis is in adulthood, so 40 to 60 years. And it's more common in men, about 62%. But certain studies actually suggest that women have more severe disease. So that's an interesting thing to keep in mind in clinic. And we know that CRS with nasal polyps really has a huge impact on quality of life. There's the Health Utility Index that shows that the index for CRS with nasal polyps is similar to that of asthma, of coronary artery disease needing a stent, end stage renal disease on hemodialysis. So, really significant conditions that impact quality of life, and CRS with nasal polyps falls right up there. Um, and in terms of what causes the impact on quality of life, we think about both the physical and emotional domains. So, nasal symptoms, again, the same ones we just spoke about, as well as cough, aggravation of asthma, and then ear symptoms. A lot of our patients really complain about this ear congestion and pain or pressure that is quite bothersome and pretty persistent. And all of this to say that then they develop anxiety, depression, feeling like you have a cold kind of 24/7 is never a good feeling, and often impacts sleep. So now, sleep is impacted. You end up with daytime fatigue as a result, and it's kind of this vicious cycle. So, real impact on quality of life. And then thinking about the inflammatory endotype, so we talk about phenotypes and endotypes. A phenotype of CRS would be whether or not a patient has nasal polyps. Endotypes digs a little deeper and thinks about the inflammatory milieu that you're dealing with in a certain patient. And if you look at this graph here, just thinking about all CRS on the left, CRS without nasal polyps in the middle, and then CRS with nasal polyps, the first thing that stands out is in red, the type 2 inflammation. So we know that type 2 inflammation is very prominent in CRS, whether or not there are nasal polyps. But particularly in the case of the patients with nasal polyps, you see a large part of that pie chart is red. And then I think what's actually even more interesting is all the other different colors. So it's not just type 2 inflammation. You see plenty of type 1, type 3, and a lot of mixed inflammation. So thinking about your patient as just a type 2 inflammatory patient will be doing them a disservice, because there might be some more to that story, especially if they're not responding to kind of the typical therapies that we use to start. And here's a little deeper dive into the pathophysiology of CRS with nasal polyps. I'm an allergist immunologist, so I could talk about these diagrams all day, but I won't belabor the point. um, the most important thing, I think, is to start at the epithelium. So at the top of this slide, you see the airway epithelium of the upper airway, and you can see that all sorts of triggers impact that epithelium. So viruses, proteases, particulants, pollutants, allergens, bacteria, fungi, etc. Once they hit the airway epithelium, they can cause epithelial disruption. And then, importantly, that trigger of inflammation, which starts with the epithelial alarmins. So, the alarmins that are shown here are the most pivotal ones that we know about, especially as type 2 inflammation inducers: IL 25, IL 33, and TSLP. And so once they get released, then all the downstream inflammation starts getting activated. And it happens through antigen independent, so more the innate immune system, with the help of that ILC2 cell that you see in the center of the slide. And that kind of starts the downstream inflammation. And then there's also some antigen dependent inflammation that is happening through the T cell. And then you see all the different cells that are involved. So we have more than just the T cell, the B cell, the eosinophil. We've heard a lot about, with IL-5 being the main cytokine that's driving that. The mast cell, which is very relevant when we're talking about allergic inflammation, but also macrophages, goblet cells, given that this is a disease with a lot of mucus production, and basophils as well. So a very kind of rich inflammatory milieu, and there's a lot of crosstalk kind of up and down in this pathway. But again, it starts at the epithelium. In terms of type 2 inflammatory comorbidities, this is a very important thing to think about in our patients, because the upper and lower airway talk. And so many patients with upper airway disease have lower airway comorbidities and vice versa. And so we have to think about the patient as a whole and really talk about the whole airway. So with that in mind, up to 65% of patients with chronic rhinosinusitis and nasal polyps have comorbid asthma. And the prevalence of asthma in the general population is only 8.5%. So you can really get a sense that in these patients, there's a much higher risk for asthma. Really important just to ask, are you ever short of breath? Are you coughing? Are you wheezing? If you don't ask, they may not mention it, because again, the CRS alone has such an impact on quality of life that will probably be their focus of the clinic visit. But ask about asthma. Many times, we talked about CRS with nasal polyps manifesting in that middle age, right, between age 40 and 60. So oftentimes it can be associated with adult onset asthma. So this is a patient who doesn't come in with a diagnosis of asthma that they've had for years. More reason to bring it up and ask about it in clinic. We also know that patients who have both CRS with nasal polyps and asthma have more severe type 2 inflammation, and this affects both the upper airway and the lower airway. So these patients tend to do worse with regards to, surgical outcomes, with regards to their asthma control. And up to 26% of the patients who have CRS with nasal polyps and comorbid asthma are the patients who have AERD, so aspirin exacerbated respiratory disease, or nonsteroidal anti-inflammatory drug exacerbated respiratory disease. Lots of different names for the same syndrome. And the idea there is you have the chronic rhinosinusitis with nasal polyps, you've got the asthma, a lot of eosinophilic inflammation, and then the aspirin sensitivity. And these patients tend to be the most severe, particularly with regard to their CRS outcomes. And then, with that in mind, the impact on quality of life is going to be worse, again, in patients who have both the upper and the lower airway involved. So, kind of looking at this graph here on the left, you can see the population norm in terms of quality of life in blue, and then in orange is going to be your CRS with nasal polyp. And there is a significant difference both in terms of the physical component as well as the mental component for those patients with CRS have worse quality of life. And then breaking it down a little further on the right, in orange are going to be the CRS with nasal polyp patients who do not have asthma. In green are those patients with asthma. And then in purple, again, that more severe category who has not just asthma, but the aspirin exacerbated respiratory disease. And you can see that there's a significant difference in all of the categories that are being compared, and it's getting worse as you go along. So the asthma makes it worse, the ARD or NERD makes it even worse in terms of both the physical component and the mental component. Um, and along with that, I mean, the patients who are not doing well are the patients who are getting oral steroid bursts and sometimes even chronic oral steroids. And more recently, we've actually been focusing on those side effects of those steroids and just how little steroids are needed in order to kind of start triggering those side effects. And so, as a community, I think we're more aware of these side effects, and it's really our responsibility to teach our patients, make sure that they're aware of those side effects. Because, again, if you're feeling miserable from this disease and you get a steroid, and that's allowing you to breathe and smell and sleep, it's hard not to want that steroid more and more. And so, really, it's our job to kind of try to minimize the oral steroids and then also educate our patients. So, in terms of numbers, 64.7% and 41% of patients used either all cause or CRS with nasal polyp related oral or systemic corticosteroids, respectively. 36% had greater than or equal to one oral corticosteroid burst, which is the equivalent of greater than or equal to 20 milligrams for 3 to 28 days. So, again, these doses stack up, even though it just feels like one burst. If it's a long enough burst and the dose is high enough, you're going to start stacking up those side effects. The use is higher in patients with asthma or those with who have previously had a surgery, because again, those are your more severe patients. And 23.5% had a cumulative annual dose of greater than or equal to 400 milligrams. So again, you can just imagine how much steroid that is. We know that the side effects that come with steroids include, affecting the heart, the brain, the bones, the eyes, pretty much everything head to toe. And so just counseling patients, and knowing that we have increased healthcare costs in terms of those patients who are getting steroids, and then of course increased downstream effects. A couple other studies here. So, at least 40% of CRS with nasal polyp cases may be uncontrolled despite receiving maximal pharmacotherapy and endoscopic sinus surgery. So, just again, referring back to unmet needs, we've got a lot of great tools, but 40% of patients still remain uncontrolled. And then a 12-year follow up study after endoscopic sinus surgery showed that 79% of patients developed recurrent nasal polyps over 12 years, and 37% required a revision surgery. And again, the patients with asthma and especially those patients with ARD are the ones who are kind of stacking these surgeries up even faster. So, can biologics help to fill the treatment gap? I will tell you, yes, it can. And we're very excited about them because they've been, I think, life changing for our patients. But the idea here is that we are going back to that complicated pathophysiology slide, and we're looking at what is driving the inflammation, and we're targeting that more specifically, so that we don't get all the way down to the downstream inflammation and mucus and all of that, where patients are miserable and needing the oral steroids. So blocking upstream epithelial alarmins. And Dr. Franzese is going to talk a little bit more about the specific therapies, but and then type 2 inflammatory pathways, so IL-4/13, IL-5, and IgE. All of these different molecules now have approved agents, and our hope is that by blocking those specific cytokines, we can lead to more sustained effect. Durable improvements, so reducing nasal polyp size, congestion, sinus opacification, all the things that really matter to improve quality of life and sense of smell. And we've seen impacts on all of these from the various biologics that are available. We talked about the risks of systemic corticosteroids and how important it is to avoid them, and also revision surgeries. So, needing surgery after surgery after surgery, if we can avoid that at all, we would love to do that. So, biologics definitely fill that gap. And then because we talked about comorbidities, these patients who are being treated for their upper airway inflammation can also be treated for their lower inflammation in many cases with the same agent. And so you can improve asthma control and health related quality of life in both the upper and lower airway, which is even more fantastic. So, Dr. Francis, let me ask you in clinic. I mean, I just talked about a lot of different things. What is the most important thing that you think, in talking with patients, kind of emphasizing either discovering unmet needs from them or emphasizing kind of how to fill in those gaps?
So I think, and you've done a fantastic job of summarizing like such a huge amount of information. talking with patients is, I think, getting to what their goals are for treatment, whether we're thinking about surgery, whether we're thinking about different monoclonal antibody therapies, kind of what are their desires, what are their expectations, um, and then how can we help with them choose the best options for them.
Yep. No, I agree. And I think we'll talk a little bit more about shared decision making, but that's where it is, right? So
I
I'll
think so.
give you the mic and you can take it from here.
I will take over with the first step in improving our nasal polyp care journey with our patients by trying to identify candidates for biologic therapy. So let's talk about our traditional approaches. Of course, nasal saline irrigations, they're the hallmark of these, the mainstay of treatment. Even if you haven't had sinus surgery, they can be highly beneficial, but there are the workhorse. In addition to intranasal steroids, topical nasal steroid sprays, or putting corticosteroids in rinses, these can be very helpful. This is really the long term treatment option that we discuss with patients. And there are several different delivery methods. It can be nasal sprays, it can be the exhalation delivery system. There are different steroid eluting stents that can be used, some in the office, some that are used in the operating room. And then off label, there are different drops and irrigation methods that you can talk about with your patients. Antibiotics, whether they are topical or oral, are useful potentially in treating exacerbations, but they don't really have a long-term place in most of our endotypes. Leukotriene modifiers can be somewhat helpful, particularly in our AERD patients that may be undergoing aspirin desensitization therapy. And then systemic steroids, as Dr. Hoyt sort of touched on, how we understand the long-term consequences of these. We really try to limit the bursts, not just the length of these bursts, of the dosage, but also how frequently we're giving them because of the adverse events that can be associated with them, the lifetime cumulative adverse events. So when medical treatment is unsuccessful, this is when we talk about surgery and potentially what the goals are for surgery. Patients may have different desires. Most frequently, if people are considering surgery, they want to be able to breathe through their nose right away. That's one of the biggest desires we'll hear. Also, can I smell again? Breathing through my nose without any kind of drainage, removing polyps, decreasing the inflammatory load. All of these are patient goals. We also want to open up the sinuses, remove inflammatory tissue, and enlarge the sinus opening so that we can deliver those topical therapies better to those involved sinuses. And then, certainly after surgery, our goal is to maintain these with these different types of therapies as well as we can, because the goal for all of our patients is really one and done. Ideally, we do one surgery and we don't have to do it again. However, polyps sometimes can be the gift that keeps on giving. There have been a number of studies that have looked at this over the years. The Daconda study from 2017 is one of the most popular cited ones. This was where we hear that like 40% recurrence potentially in 6 months and then at 18 months. One of the caveats to this is in that study, the polyp size wasn't necessarily rated other than a polyp had come back. It could be a small polyp, could be a very large polyp, but essentially it was just noted whether there was a polyp or polypoid mucosa. But still, polyps do tend to come back in some of the newer endoscopic approaches because we're all aware that sinus surgery has really evolved not just in the last few decades but even in the last decade. The treatment approaches, the targeted approaches, the what we can do endoscopically has really markedly advanced. And so with these new different approaches really targeting where polyps are coming from, a 2-year polyp recurrence can be as low as 10% or less. And but we do know that sending tissue from surgery can be helpful because if you have a lot of markers of type 2 inflammation in that tissue, that usually is indicative of more severe sinus disease and does elevate your risk of potential recurrence. So here we have that beautiful diagram that talked about the different cytokines and cells that are involved in this inflammatory cascade. And you'll see now there are some red additions. These are pointing out the different areas where we have monoclonal antibodies that potentially can block either these different antibodies, these cytokines, or act directly on cell receptors. So we have tezepelumab, which got newly approved, which is a anti-TSLP blocker. We have omalizumab, which is an anti-human IgE monoclonal antibody. We have two different antibodies that will target IL-4 and IL-13, dupilumab and stepokibart. Now you'll notice stepokibart, the BART is new since 2022. The naming conventions have changed, so we'll have to get a little used to that. We're not going to see MABs anymore, at least from the newer ones. And then we have mepolizumab as well as depemokimab. Those are an IL-5 cytokine blocker, and benralizumab actually binds to the IL-5 receptor itself. So it's really exciting. We have a number of different therapies that can target this inflammatory cascade. So here are the currently approved biologic therapies: dupilumab, omalizumab, mepolizumab, and tezepelumab. You'll note that dupilumab and tezepelumab are for 12 years old and up, whereas the other two are for 18 and up, so adults only. And you'll notice a number of them are actually indicated for other type 2 inflammatory conditions. So, when we look at the severity of disease, how can we assess this? What are good ways potentially to measure it? Well, some objective measurements include nasal polyp scoring. So there's no one specific scoring system that is universally used or advocated for. There have been other ones used in FDA approved studies for nasal polyps. The most common ones feature a 0 to 4 scoring system where you grade each side and then add them together for a total maximum of 8. But there can be other ones that use numbers and letters. There's also not an MCID for the scoring system. So, what is clinically meaningful may vary depending on what system you're using. The SNOT 22 score is a quality of life validated measure that goes from 0 to 110. That does have an MCID of 8.9. But generally, anything over 50 is considered to be severe disease. And that's usually what we'll see enrolled in our nasal polyp trials. The VAS is a visual analog scale, generally from 0 to 10, with each one marker being 1 centimeter in size. Again, if there's an MCID, it may vary depending on what you're doing, but we're usually looking for a change in score of 3 or greater. And then there's different olfactory testing. There's the upsit testing, there's sniffing sticks. Again, what is the scoring range will differ by the test, whereas the upset is a 0 to 40. And what part of that is anosmic versus hyposmic is going to vary depending on your age and gender. And again, the better the score, the better your sense of smell. And then what olfactory score you're using, that change may the amount of change you have may vary depending on the system that you're using. So, what are we looking for when we're thinking about potentially initiating treatment? Well, first is we want to confirm we're dealing with severe uncontrolled nasal polyps. There are some things that masquerade. So, if you're not unsure, biopsy can be very helpful. We do want to check for other comorbidities such as NERD, asthma, atopic dermatitis, which is unusual to see in our nasal polyp patients. We do want to check that type 2 inflammation is highly likely because you can see that many of these monoclonal antibodies target type 2 inflammatory cytokines or parts of that cascade. And then talk to the patient about their different treatment options, what they want, what they expect, and then whether they're interested in surgery or not. But these two things are not mutually exclusive. And look and talk to them about which potential treatment options we should select. If you are dealing with asthma, particularly severe asthma or other comorbidities, do you want to this is really a multidisciplinary disease. You want to get your allergist, immunologist involved, you want to get your pulmonologist. Really, many eyes can be very helpful in getting the best outcome for your patient. So, in identifying patient candidates, we have our EPOS euphoria criteria. If you've had sinus surgery before, again, we're either looking for different types of type 2 inflammation, different markers for tissue eosinophilia, blood eosinophilia, or elevated total IgE. Have they had multiple courses of systemic corticosteroids? Have they lost their sense of smell? And do they have a diagnosis of comorbid asthma? So, we're usually looking for three of these particular criteria. Before we move on, I want you to take a moment to answer a follow up poll on identifying patients for eligibility in biologic treatment. Let's quickly talk about the stepwise algorithm for the management of CRS with NP. Now, this does look a little busy, but the gestalt is that the majority of patients, sinus surgery is really the first line for treatment. Many patients actually will respond well to targeted sinus surgery. And like we said, the way that we do sinus surgery has really evolved over the last 10 years. Postoperative management will definitely be saline rinses, may involve other topical nasal sprays. But if they don't respond well to this, if there is recurrence, then you can see, depending on their comorbidities, if they have AERD, you may do aspirin desensitization, they may consider a steroid implant, or you may consider a monoclonal antibody. There will be, though, very severe patients that start out. Our AERD patients tend to be more severe, and they may not wish to have surgery. They may have already had surgery. They may have had a contraindication to surgery, and we may consider going right to biologics for these patients. So let's quickly talk about a case. This is one of my patients, actually. Chris is a 12-year-old boy, and he was referred to me from Peds Pulmonary for nasal congestion. He does have moderate asthma, but he had a really thorough workup from my colleagues, ruling out cystic fibrosis and primary ciliary dyskinesia. Now, he does have some allergies, mainly in the spring and fall, with nasal congestion, runny nose, and itchy and watery eyes. But his concern was he could not breathe through his nose. He had no sense of smell. He had some facial pain and pressure, and drainage that was constantly going down the back of his throat. Incidentally, he's also seen by endocrine. He's small for size. He has started on some growth hormone replacement. He has never had any kind of surgery before, and he's on a few medicines for allergies and asthma, but he's really well compliant with him. This is his sinus CAT scan. To just quickly touch on this, these are three different coronal cuts. Anything you see that is white is bone. Anything that you see is black, that's air, and anything else is gray. That's all the other stuff in between. Skin, muscle, you'll see his eyeballs there. But the thing is, where his sinus cavities are, we should be seeing black and white, air and bone, and you'll notice that maybe there's a few bubbles, a few little black bubbles in there, but there is a lot of gray in this poor kid's nose. And that goes with what I see endoscopically. Now, if you've never seen nasal polyps, this is an endoscopic nasal view of the right nasal cavity and the left nasal cavity, and you'll notice that they look like these grapes that have had the skin peeled off of them, although there are just as many colleagues that tell me they look like cocktail onions. But you'll notice they are filling up this poor kid's nasal cavities. So, Dr. Hoyt, how would you treat Chris? Do you think he's a candidate for biologic therapy?
Yeah, that's a great question. I mean, he is a very complicated case, especially for a 12-year-old. Seems like he's had a very thorough workup to make sure that, you're not dealing with a secondary condition that's predisposing. I think here is, you mentioned the importance of multidisciplinary care. And so I think if he was in my clinic, I would right away get my ENT colleagues involved. You showed the algorithm where a lot of patients can get that one surgery and be in such a better place and maybe not need another surgery, or at the very least do a lot better. So I would start there, send to ENT, see if he's a surgical candidate. Certainly with a 12-year-old, you're going to have to get the whole family involved in that patient shared decision making. And he's going to have a voice, his parents are going to have a voice. And then, depending on how he does, I think he's a great candidate for biologic therapy in terms of the amount of inflammation that's there. So if those polyps recur, if they recur more quickly than you'd expect as an ENT surgeon, I think, there are now two biologics that are approved down to age 12. So dupilumab and tezepelumab would both be options. And, he has some other comorbidities. So the allergies, I think, would get better with both of those. Although I don't think the allergies are really relevant in terms of his chronic sinus disease and nasal polyps. His asthma may improve. He may be able to back down on some of his other therapies. So I think he makes a great candidate. But if he has a surgery and does well, then maybe he doesn't need them.
I agree. I think he is a candidate for biologic therapy. He's a candidate for surgery as well, but the awesome thing now is that he's got options. Before, he really didn't have many options. So I think having this discussion and involving, like you said, all the stakeholders can be really helpful in getting him the best result. So before we move on, let's take a moment to answer this question. So please take a moment to answer this follow-up poll on the timing of biologic therapy. So let's summarize all that we've talked about in our in these like really high yield 30 minutes. So chronic sinusitis with nasal polyposis is a chronic type 2 inflammatory disease. It does cause a significant burden on our patients in their quality of life, and there does tend to be unfortunately high recurrence rates. Now with better surgery that has changed, but even with the best surgery and our most compliant patients, it is a fact of life, unfortunately, that polyps do come back. Looking at the patient's comorbidity, such as asthma or AERD, can be helpful in trying to target what the best therapies are for them. And monoclonal antibodies can really help us target that treatment gap by really honing in on these key upstream inflammatory mediators. And the goal is for all the stakeholders to get together to communicate and help identify with shared decision making the best options we have for our patients' treatment. It is really critical. So thank you all for joining us tonight, and thank you, Dr. Hoyt, for providing your insights to this discussion. Please visit peerview.com, T2 and CRS with MP-ARS to claim credit and access activity materials. We hope you found this activity to be useful for your practice. Please join us on Tuesday, November 4th for part 2 of our series, Navigating Treatment in Type 2 Inflammation-Driven CRS with NP.